we're going to talk about asthma in pregnancy. Asthma is something that we will deal with in your pregnant patients. We do see this occur sometimes even in women who haven't struggled with uh, any asthma before they were pregnant. And so it's something that I want to make sure that you have some clarity around, because there wasn't a whole lot about it in the antepartum section. There is a little bit more about it in your primary care section of Varney, so be sure to review that. So asthma affects about 8% of pregnant women. And with pregnant, we will see that 1/3 of them, their asthma will stay the same. 1/3 of them will actually worsen, and 1/3 of them will improve. Now, this is just generally speaking. It's not like this hardcore, but kind of a rule of thumb. Their past asthma history, how long they've had it, and how well controlled they've been is really important data to collect if they come in. As those who have really poor control prior to pregnancy will have a high chance of having worsening asthma during their pregnancy. So if they've come in and said, have any history of asthma, you want to unpack that history, pause and really unpack that history during your initial OB assessment. So asthma, hopefully, as you all know at this point, it is an allergic type inflammatory response into that respiratory tract. It is caused by a bunch of different stimuli, which I'll have in another slide here. The bronchioles in the lungs, they constrict. It's either from an allergen, an irritant, or sometimes even infections. It causes people to feel breathless. Sometimes they feel like their chest is getting really tight. They may cough. Sometimes they even have sputum production. The adverse effects in pregnancy, these aren't fully established, but we do see they have a small increased chance in developing preeclampsia. The preterm birth and the low birth weight are often related to that decreased oxygenation to the placenta. So again, it's not fully established, but we are seeing that increased risk. So these common triggers that we see are all related to an allergen or an infection. So smoke and chemical irritants, air pollution, dust mites, dander. Sometimes seasonal changes can trigger it, as we see more irritants in the outside world, so pollen, molds, and spores. Sometimes I see it like when the heat kicks on in the wintertime. Any dust that was in the air ducts then gets pushed into the house, and people get triggered. Upper respiratory infections, reflux. So think about that as the pregnancy progresses and the diaphragm is getting pushed up, and they have more reflux. That can trigger their asthma. NSAIDs and aspirin can trigger them. Exercise, cold air, and stress. And heaven knows, lots of stress in pregnancy. And remember, emotional stress doesn't mean negative stress. It can be happy stress too. So happiness about the pregnancy, happiness maybe about getting married, or a friend who has getting married. So it doesn't have to, don't think of stress as necessarily being a negative thing. It can be a positive stress as well. So I made this chart, I copied it straight out of your Varney textbook. But the very first step when we are treating someone with asthma is to determine which classification she is. And this is based on the National Asthma Education and Prevention Program. And so we look first at trying to determine what disease severity is. Is she mild, intermittent, persistent mild, persistent moderate, or persistent severe? And so we look at her daytime symptoms, her nighttime symptoms. We're looking at her volume, her interference with normal activity, her use of short-term acting medications, and then any exacerbations per year. And that will give us a clue, at least, of how to treat her best. And so, again, this is right out of the primary care part of your Varney textbook. And so that at least gives us an idea then of where she is classified. So our treatment goals are to really prevent her chronic symptoms. We want to maintain as much of her pulmonary function so that she can have normal activity, because that and we want to prevent exacerbations, but really what we're really hoping to do is keep her oxygenation well, and keep her from having hypoxic events so that the baby's oxygenation is at optimal levels. And then obviously avoid any medication side effects. We're always wanting to do that in pregnancy. So the primary goal, like I said, is to keep that baby well oxygenated. And the management otherwise isn't significantly different between a pregnant and a non-pregnant woman. So we define adequate treatment as minimal chronic symptoms and minimizing any exacerbations, keeping her pulmonary function as normal as possible so that she can have normal daily function, and then keeping her rescue inhalers to a minimum. If she's having to use her rescue inhalers, that's a sign that we need to up her daily medication usage. So we use that step approach. And that's an attempt to use the least amount of medication to control her asthma. So we also will want to be doing serial fetal monitoring. I wrote serial fetal movement counts, but it's really serial kick counts. That's another way to say it. And serial ultrasounds, because we're worried about that fetal oxygenation, and one of the ways that we can make sure that baby is not at risk for that growth issue is by doing this monitoring. So we will want to establish that antenatal testing with these kiddos, especially if she is in that that classification, those elevated classifications. So here, like I said, we want to ask about the severity of the number of episodes, how many hospitalizations she's had, and the number of medications she's used in the prior year. And that's really going to help us determine what classification she is. And then we really treat on a stepwise approach. So we always want to start as low as possible and then step up when control is not reached. And then once we have her at good control, then we would step down when we have that resolution of symptoms. So if she's not using daily meds, then we can give her an albuterol, PRN. If we need to step her up, then we go to like a low-dose inhaled corticosteroid. And this comes this is right out of your Varney textbook. This is not reinventing the wheel. And you can see here, so then if she's moderate persistent, we would maybe add in Advair as a rescue inhaler, or we could give her a medium-dosed inhaled corticosteroid. And if she's severe persistent, we would probably be sending her, I would not be managing this all by myself. I would be sending her to a primary care doctor to be managing her asthma. I'm comfortable giving an albuterol inhaler. Like I'm pretty comfortable doing mild persistent and mild intermittent, but if she's getting to moderate persistent at that point, then I think she needs to be managed by primary care as well as myself. But for managing her asthma, I can do mild persistent and mild intermittent, but after that, I want her managed with primary care. But I definitely want to be knowing about her asthma and what's happening with that, because I want to be monitoring that baby, and that's where I feel like it's our job as a midwife to make sure that we are very well involved with her asthma management. So, things that we want to be doing as educating our patients is really educating them, especially if this is something newer for them, like maybe they had just exercise-induced asthma or they thought they had grown out of their asthma, is really making sure that they know the signs and symptoms and the progression and the exacerbations, because they might be someone who isn't prepared for that, so that we're really, really making sure that they're on top of that. And also monitoring and helping them understand the importance and the safety of the medication for the fetus and herself. A lot of times women, especially women who seek out midwifery care, are all about not taking medicines, and they really are hesitant to dose themselves, because you say corticosteroids and that just sounds like a big scary word. I don't want to take that. I don't want to put that in my body. That sounds bad. And they'd rather huff and puff than take medicine. And so what you really need to do is educate them on the safety of this medication, but even more so, you need to like talk to them a little bit about the pathophysiology of asthma and how it's dangerous for them. It's actually more dangerous for them to not take the medicine because that baby is not getting the oxygen that the baby needs, and how that can actually impact the baby in really profound ways. So it's so important for us to help them kind of understand that risk reward ratio between not taking the medication and taking the medication. We want to let them know like when to call, what warning signs to be looking for, when to seek ER care, because asthma can be dangerous, and when they would need to, they might need to go to the ER. I covered this potential harm to the fetus when under treatment, especially if they don't seek treatment. How to prevent and avoid known triggers if they do know what their triggers are. How to use an inhaler. I think that's sometimes a tricky thing too. Not everyone is good at doing the inhaler, so sometimes it's important to actually demonstrate and show them how to use the inhaler so you know that they're actually getting the medication. And then, of course, to review any of those adverse side effects. So that is the end of this. It's just a short little lecture here, but that is all I wanted to go through today, in hopes that that just gives you a little bit of a highlight. I know it feels overwhelming to think about classifying someone, and I'm going to pull that up a little bit here again. I know this feels like a lot to think about classifying someone, but I think this actually breaks this down really, really well. And if you're ever not sure, especially at the beginning of your practice, of course send them to primary care. But I think most of the time, this little chart here helps. I think it's just a really, really good chart to help you know where to place someone. And if you're ever uncertain, you can always refer them to primary care and then co-manage with them. And that's the beauty of at least our healthcare system, is that we can do that. But if you're in a situation where you don't have that option, this is a good place to start. And you could always start them low with an albuterol inhaler. And then if that's not working, then work your way up. Do that stepwise approach. And that's really the two takeaways from asthma management. So if you have any questions, as always, post them in the general forum. Otherwise, have a great day.